Break it down.
So welcome to the breakout that is splendidly titled The Omnibus Privacy Rule, Are We Done Now? When we chatted about this last week, we thought that there were about 3 different questions implied by the title that was thrust upon us. First of all, what do we think, or what reflections do we have on what the Omnibus rule actually achieved? Secondly, what's left on the privacy, security, regulatory agenda? And third, sort of what's maybe in the pipeline, what can we expect? So to answer those questions, and no doubt others that you will bring forward, we've got a splendid panel. Their bios are long and impressive and are in your materials, so I won't go through them. My name is Nick Terry. I'm from IU School of Law, where I do health law quality and health information technology. The first of our speakers will be Candice Weatherly of CenterLight Health System, then Brian Selfridge from Meditology, then Sherri Morgan from the National Association of Social Workers, and then Sue McAndrew from the Office of Civil Rights. So I thought before we started, it might be a good idea to talk briefly or try and answer the question, what exactly are we talking about? When I was a first-year law student, I was taught that the definition of negligence was set by the man riding on the top of the Clapham Omnibus. We don't have omnibuses anymore, so I guess the word has come to mean slightly different things. Literally, of course, it means containing many things. But I think we tend to have a popular perception of it today as being a compendium, as being complete, connoting an all-embracing approach. So if that was your belief, the Omnibus rule may have dissatisfied you somewhat. It is a container of many things, not necessarily a compendium of all things, good or bad. So what do you get for reading your 562 pages? I omit the 563rd, which is blank in the published document. How many of you have read them? There will be no test. Okay. So, well, the first thing you get for investing in those 562 pages is a quite extraordinary commentary. It is one of the most valuable commentaries I've ever read on HIPAA and high-tech. It is relatively transparent, and it is a source of great knowledge. It is something we should be relatively familiar with. Beyond that, what are some of the more important changes? And everyone, I'm guessing, on this panel will have a different list. But just to give you some kind of frame for the discussion that's going to take place, the Omnibus Privacy Rule finally makes business associates of covered entities directly liable for compliance with certain HIPAA privacy and security rules. Those business associates are themselves responsible for their downstream subcontractors. At the most practical level, all of the BA agreements out there will need updating to reflect that reality. Secondly, the Omnibus rule strengthens the limitations on the use and disclosure of protected health information for marketing and fundraising purposes, although in subtly different ways, and prohibits the sale of protected health information without individual authorizations. Talking of authorizations scattered through the Omnibus rule, we seem to have a slightly different approach now to compound authorizations, which generally are not permitted. A relatively minor issue, but I think in practice a complex one for providers, is that there are now quite complex issues regarding how to handle requested disclosure limitations for patients paying out of pocket. And the complexity there leads to changes, or likely changes, in physician workflow to deal with data segmentation. So that might, for a relatively small piece of the rule, that might actually have some broader impact. The final rule on breach notification is probably was the greatest substantive change from perhaps what we were expecting, in that the breach notification, the interim rules harm threshold was replaced with a more objective compromise standard and a presumption of compromise with a 4-point assessment that then falls in. And you know, missing out on some of the GINA stuff and some limited data set stuff and things like that. I'll finish by, again, a very practical point, which is providers will have to replace their notice of privacy practices. And so that's going on. And that brings me to sort of my final data point, which is all of this kicks in on September 23rd. And by my terrible math, that is 109 days from here. So given that you have to change your privacy notices and redo all your BA agreements, what the heck are you doing here? You're busy. So without more, Candice.
Okay. First off, thank you all for having me. I work for CenterLight Health System in New York, so I'll just give a brief background of what that is. We are an integrated health system. On one side, we are a long-term care provider. We have nursing homes, long-term care facilities. And then on the other side, we have our healthcare side, our health plan side. We're a managed long-term care organization. So I'm going to speak somewhat from a dual perspective, but a lot more actually from the health plan side as a covered entity in that respect. As for the title, are we done? No, I don't think so. I'll just say it like that. And what I'm not going to speak on is actually the breach notification requirements and those changes, just because I think I would go on for far more than my allotted time. So I'm actually first going to address really what I think was left out of the Omnibus rule that is one of my biggest challenges as a privacy professional and a compliance professional, is the kind of silence on mobile devices, right? And how do we manage that and the requirements coming out of that? You know, we have requirements for encryption and encryption solutions and managing that, but there really was a lot of silence specifically to mobile devices. And as we've learned, if you didn't know before, as we've learned over the last 2 days, that's where we're going. That's the move and that we're going into as healthcare institutions and organizations, is tablet usage and mobile device usage, just in terms of your handheld device. And from my perspective, especially on the healthcare side, we are dealing with hundreds of nurses who, so not just physicians, but nurses who are on a daily basis. We are not providing care in one specific place, but we're doing home visits, we're doing home care, we're doing health assessments. We're on the move. We are mobile in every sense of the word. In one day, a nurse can be in 12 different locations possibly. So everything goes with them. And in the past, our headache was, you know, can everyone hear me? Just want to, okay. So in the past, our headache obviously was paper. You know, paper, it's here today, gone the next second. It's hard to contain. So with these mobile devices, you know, that alleviates some of that headache, but it comes with new headaches. And when I'm doing training, I always like to remind people, you know, a mobile device, a tablet or a smartphone can contain far more data and information than anyone would ever be able to carry in paper form. And the ramifications and fear that comes out of that for me is really trying to get across to these staff members, especially these nurses, what that means. So I guess I can say what we've done is to require remote data wipe software on our devices. But the fact that that's not actually a requirement through the Omnibus rule, I think, is where it's really lacking, because encryption only goes so far. But being able to actually remotely wipe the device is where you really want to be. And I will say that from that perspective, what we've had to do is readdress our mobile device policies. And on the other side, in this whole bring your own device to work world or culture that we're in, I don't know about all of you, but there's an increasing demand in my organization for people to use their own devices, their own tablets, their own smartphones for work, whether it's someone actually accessing health records and medical records of our patients or members, or if it's just as simple as email, where perhaps in an email the member's number comes through, or the Medicare number comes through. And if any of you were in the breakout session yesterday about the value of this data to organized crime, you'll know that you can do so much with even just your Medicare number, right? So even just someone who just has access to this data as simply as email, there's an extreme risk there. So the other thing we've done is just try to increase our education and explain to people what the risks really are in these devices, and especially when using your own personal device. Because I don't know about your organizations, but I find, unfortunately, with a lot of our staff members, I don't think if they lose their own personal device that they're using for their work purposes, that the first thing on their mind is going to be our patients and our members and the risk of their information, unfortunately. For some of these people, they're thinking, I lost my pictures, I lost my photos, I have to replace my phone, I have to go through that expense. So really, it starts with the education piece of your staff members, I think, and also outlining user agreements. That's something that we've really boosted in the last 3 months. We've created these user agreements that outline not only for company-owned devices, but especially for personally owned devices. And we're requiring that we install this mobile data wipe software on any person's device if they're going to use their personal device for CenterLight purposes. But that only gets us so far. If we're dealing with non-PAR providers or community providers, physicians, I should say, as well as some fee-for-service nurses who are contracted and not necessarily our employees, and especially with business associates, our user agreements and our policies don't extend to them. So if they're not required to follow these steps, we're still at a severe risk. So that will take me also to my next, issue, so to speak, with the Omnibus rule, which is business associates. Certainly having the direct liability now for certain violations of HIPAA extended to business associates is absolutely welcomed, I think, by covered entities. However, expanding the definition of a business associate and also extending this business associate relationship to a business associate subcontractors kind of, for me personally, threw me a curveball. And in many respects, one second. I think from a patient privacy perspective, this is good, right? We want to know, it behooves us to know who our business associate subcontractors are and what kind of relationship they have, and knowing that they actually have a written relationship that outlines how they in turn are going to use this information. But at the same time, from a practical perspective, what does that look like? You know, for one thing, we have to reevaluate our business associate agreements. We have to revise them. But you also have to start looking at that relationship again, and then looking at their relationship down the line. And when you're dealing with potentially hundreds of business associates, how does that happen? And from a covered entity's fear, also if there is some kind of agency relationship, so now you can be vicariously liable for their violations, how do you go about really doing your due diligence in knowing, okay, you have your relationship with the business associate, you've revised your agreement, you know what's expected, you know that they have their policies and procedures, but what about the people on down the line? What about these downstream entities? And what are they doing to oversee and monitor that? And we can't do that, right? We can't oversee and monitor every single subcontractor of every single business associate. So really, what that's going to look like. And I know, there are education initiatives expected from the OCR to these business associates. But at the same time, I think it goes also back to the covered entity to really make sure that you're educating your business associates on what this relationship really means. I think people got very reliant on, oh, we have a BAA, we have a BAA, we have a BAA, especially if you don't have a structured business associate process in your organization, which unfortunately happens where, if this department has access to BAA, next thing you know, they have a new business associate and you didn't even know about it. And, well, they signed it. Well, what does that mean? If they don't know what it means, and especially now, if, with their liability now on the line for violations of HIPAA, just because you signed something, as we all know, means absolutely nothing. And even just in a recent visit to a potential vendor, I saw that where, oh, well, yeah, we can do your BA. If you want us to sign a BAA, we will. And it was very clear, you don't even know what that means. So how is it protecting me? And I can do my education to you, but if you don't know what it means and I have to educate you, what are you doing to your subcontractors, if anything? So that's, I guess, my two little points on Omnibus and what's missing maybe or what needs to be expanded. So.
Thank you.
Well, I got to say, Candice, thank you. You've very, very eloquently laid out just the one topic I wanted to talk about today around business associate compliance. So thank you for that. But before we do that, I guess I'll start in terms of introduction. So my perspective, my name is Brian Selfridge with Meditology Services. I come to this from an industry perspective very similar to Candice. So we provide healthcare, privacy, and security consulting services for covered entities and payers primarily. So I'll be looking at it from that angle, and just by way of background, I spent the last 5 years or so as a chief information security officer of a hospital system. So these topics are very near and dear to my heart as well. So Nick, to your outline, your question I think is well framed around what did Omnibus do. First and foremost, Omnibus maybe not as comprehensive as you said of all-encompassing of the universe, but it's certainly the strongest and most comprehensive set of regulations and requirements to date that we've had, and I think that's a significant and important step forward. So areas like business associate and subcontractor requirements are more robust than they ever have been in the past. Some of the definitions of willful neglect and business associate definitions themselves have been well defined. We have more penalties and increased enforcement, more so than we've ever had. So these topics that we've been talking about, I think we're better positioned now than we've ever been historically to take action on some of these areas and have an impact. But certainly there's still more work to be done, and I think at a baseline, some of the topics that we've been talking about all week have been highlighted around areas that we still need to work on. So data analytics and large data sets being transmitted and shared, and making sure we get the right protections around those data sets, making sure that we have the appropriate governance, I think is a topic needs attention. Some of the emerging technology areas that Candice had highlighted, I think absolutely still need attention. We've talked about consent models to some extent, and sharing consent across platforms still needs some effort there, as well as what I'll call kind of ultra-sensitive data types like your HIVs, your psychiatric information, and some of our panelists will have some insight there. But there's still more work to be done to figure out how we treat those sensitive data types either more stringently or differently from the way we do the rest of protected health information. So those areas, I think, in a nutshell, still need to be addressed. But I wanted to focus some time with the group around the business associate challenge in particular, and more so than just highlighting and framing the issue, which I think Candice has done very well. Talk about what we're seeing in the industry in terms of practical approaches to actually start to tackle this challenge. So there's a number of typical approaches that we see in the industry to dealing with monitoring business associate compliance and subcontractor compliance as well. First and foremost is the approach that Candice mentioned, where, okay, you start with issuing out an updated BAA, a business associate agreement, make sure it's got all the right provisions and all the right requirements in there for breach notification and the rest. But at the end of the day, it's a piece of paper, and until those associates understand the requirements and can actually demonstrate that they're doing the things they need to do to protect privacy and security in alignment with the contract, then in my mind, that's a very, very bare minimum baseline that doesn't do enough to really tackle the challenge. Certainly, we should pay attention to the legal side and getting the agreements done. But that's unfortunately, we're seeing some organizations just take that step and stop and walk away, and so that's from our perspective is not enough. Other organizations will go as far as to do what I'll call a manual survey-based approach to deal with business associate and subcontractor compliance. So what that tends to look like is, okay, we send a survey of our 100 or 200 questions for privacy and security to our business associates and partners, and we say, please fill this out and tell us how you're doing all the right things from a security and privacy standpoint. So that cycle, then they fill that out, they give you some responses, you maybe have some back and forth, looking at the adequacy of those responses and making a risk-based decision at some point. That process itself, just from a methodology standpoint, makes sense, and it's a much better way to get a handle over the compliance activities of business associates. However, it's not particularly scalable. It's labor intensive, so if you, speaking from the perspective of a security officer, I would do these things and we'd send a survey out, get the responses back, make some negotiations in between, and that could take anywhere from, at best, 5 to 10 hours per vendor, per associate. And when you're dealing with, and our organization had over 700 business associates, and candidly, we hadn't even figured out the business subcontractor relationships. Now that they're on the radar, that's wonderful, but it's taken that number and it's somewhere now in the thousands. So you extrapolate that out into the level of effort and hours it would take to get that survey process working effectively, and you realize very quickly that there's no way to get a comprehensive control over your risk posture and those folks that have and are managing your patient data or sensitive data for that matter. So the survey model has some gaps. Also, one problem with the survey approach is that the vendors tend, I say vendors, but business associates tend to want to paint themselves in the most positive light. And that's certainly understandable, but it makes it very difficult to actually understand where the true risks are. So, for instance, we used to have questions on these surveys that would say things like, please explain how you're monitoring vulnerabilities in your environment and making sure that they get closed up. And the answer would be, we are HIPAA compliant. And I was like, well, okay, the time it takes for me to go back and say, okay, that's not enough, please clarify, takes far too much time as a process. So what some organizations are doing as a maturity level beyond that is trying to automate the process a little bit. So they have web-based products that can send out a survey more quickly and efficiently, can do some sort of basic level risk rating over the responses that are provided from the business associate and deciding whether or not those are compliant or appropriate from a risk management perspective. And the automation helps. So maybe you get that survey time down from 10 hours to 4 hours. But again, you're dealing with thousands of business associates, and I'm not sure that most covered entities still have the staff even to work through the automated model. So not to worry, there are other solutions. This is not a doom and gloom conversation. Our organization, so Meditology and others that have tried to think creatively and innovatively about this problem, have thought there's got to be a better way as an industry to tackle this challenge. So we've put together a model, and again, others have gone along this line of developing kind of a credit score for business associates. And I say a credit score because I'll use an analogy. If you were to go to Best Buy to get to buy a piece of equipment, the way the industry works right now is, in that analogy, would be you go to the teller and they'd ask you for a statement of your bank amount, your credit history, they'd ask you for all these data inputs, and then they decide whether or not they want to give you that product on credit. It's far too time intensive, doesn't really make sense. So they rely on a credit score and some estimate of your trustworthiness as a consumer to provide you with that credit. From a business associate standpoint, we can do the same thing in this industry. If we look, for instance, at the most common electronic health records platforms or the common vendors and business associates in the industry, provide them with a credit score based on what confidence we have that they're doing the right things from a privacy and security standpoint, and disseminate that out to the industry, it provides a much more scalable way of communicating which vendors and which associates are doing generally the right things. Now, it's not a replacement for vendor due diligence. It's not a replacement for still following up and making sure that your data is protected, but it certainly is a much better starting point and gives a capability for being able to scale up to those thousands of vendors by having one entity do the rating, and then you take those inputs and decide whether or not there's further conversation needs to happen. So I'm running short on time, but suffice to say, there's a lot of work to be done in the business associate due diligence space. In particular, there's a lot of effort on the covered entity side to address the challenge. I think there are ways and are innovative ways to tackle this, but we need to come together as a group and work through it. So that is my time. Thanks.
Oh, sorry.
Thank you, Brian. Hi, I'm Sherri Morgan, and I'm Associate Counsel to the National Association of Social Workers. I've been coming to these meetings for a while now and seen familiar names and faces. Many folks aren't aware, actually, that social workers are one of the largest single groups of mental health providers in the country. And in my capacity at the association, I have the opportunity to hear from our individual members on a daily basis on questions that they have regarding privacy and HIPAA compliance. And so I guess the review that I've done on this topic is related primarily to mental health information, and also then with a particular concern for the needs and limited resources of small providers, because those are the ones that tend to contact us. The folks that are employed in a larger agency or organization are working together, in that setting with compliance officers and resources. So some of the areas, and I certainly want to reiterate the other, what the other speakers have said in terms of the increased protections and positive aspects of the Omnibus rule. But just in the interest of time, I'm just going to skip over to some of the challenges and concerns that remain. One area, and this is sort of an old area, that's been of tension certainly between providers and payers, has to do with how and who interprets the application of the minimum necessary standard when mental health provider submits a claim for treatment. It may be paid for a month or two over a period of time, and then at some point it's not uncommon for the clinician to receive a request that is for a lot more data, and perhaps an entire copy of the patient's mental health chart, which alarms the clinician from the standpoint of the type of data that's contained in that and how that may expose the patient's information. And it's not just from the provider side, but patients share those concerns as well. And the patient also has, of course, the fact that they would like the services to be reimbursed by the health plan. And so there's some tension there when a provider may interpret what is the minimum amount of information necessary to process, a claim for reimbursement of the service, versus what the health plan may view as a legitimate area. So I don't know, and I'd be interested. I'm very interested to hear what Susan has to say about all of this. We want her to just answer everything.
Sure.
To see what, to what extent OCR is looking at that, or how they might address those conflicts. Because when I inform some of our small practitioners about, well, there is this minimum necessary standard, I don't always get feedback from them of how that conversation went. And whether there is an opportunity for any meaningful negotiation of how that's applied. But actually, my more main point that does relate to the Omnibus rule is this new provision that the Notice of Privacy Practices is now to contain a statement regarding the release of psychotherapy notes. And I'd find it curious to know how many of you think you know what that term means, psychotherapy notes. When I give presentations to mental health practitioners, they all think they know what that term means. And the HIPAA definition is really a more narrower subset. It has to do with the content of a counseling session to the extent that those notes are maintained separately from your primary medical record. And it's optional. So if one goes to a clinician for a counseling session, you wouldn't necessarily know whether they are keeping a separate set of more private notes, maybe verbatim things that the client has said, or contents of a dream. But this is the meat, the daily meat and potatoes of psychotherapy. And so the clinician may find that very useful for continuity of the sessions from week to week. But there's also the primary chart, which would have more summary information, but still fairly sensitive data, including summaries of diagnosis, goals, symptoms, level of functioning, medication monitoring, intake information, and all of that. So now we're going to see kind of how this plays out with putting a statement in the Notice of Privacy Practices that information relating to psychotherapy notes requires an individual authorization before that can be released, because that only applies to that narrow subset. It doesn't apply to the rest of your mental health chart. And so one thing that I could anticipate is that first of all, it will require mental health providers to really go through maybe a renewed analysis as to whether or not they're going to choose to keep those separate notes or not. Because if they do, then they need to put that in the notice. And I guess one of the questions I have is whether how valuable the information in the notice will be for patients, or whether it will be more confusing or cause them to think that their information is more protected than it is. Because certainly the separate psychotherapy notes are more protected. But if the patient thinks that term encompasses their entire chart, that could be confusing. And I know the psychotherapy notes provision, when I do trainings for social workers, is one that I have to explain about 4 or 5 different times. And these are people that are in that field. And so that's on a going forward basis to see how that plays out. Will be something we'll be looking at closely and trying to educate social workers about. But I also think that there'll be some useful conversations between the providers and patients about how that information is used. And then the other aspect of that, of course, is that the patient does not have a mandatory right under HIPAA to access the separately maintained psychotherapy notes. That's not required to be put in the notice. So it's kind of a complex area. And since it's in the Omnibus rule, I think we'll be seeing how that plays out. The other aspect of that, of course, is that most mental health practitioners are subject to their state licensing rules or confidentiality rules, which in many instances are more protective of privacy than HIPAA, and their ethical standards. Like, for example, the NASW Code of Ethics states that you don't release information to a third-party payer without the written consent of the patient, or at least the consent of the patient. And so the extent to which a solo practitioner has to revise their Notice of Privacy Practices and incorporate into that their actual standards, what they actually are carrying out, which may be more stringent state law, more stringent ethical standards. I'm wondering, to what extent OCR is sort of monitoring all of that, or whether they're just looking at HIPAA, because a lot of trainings that I go to, HIPAA is just used synonymously with privacy or confidentiality. And I even hear this from our members. I have a HIPAA question, and I go through with them and I find out they're not a covered entity. They don't have a HIPAA question. They have a confidentiality question. So some of these complexities, right now we're dealing more with security breaches and things like that, which I think are extremely important. And the rules, I think, have brought a lot to the table with the awareness in healthcare on the importance of that. But the way some of these other things are played out, I like to hear, and then maybe we'll just have to see how that gets rolled out. One area for future enforcement that I know a lot of folks are on the provider side are interested in, and this is beyond mental health, has to do with how and to what extent HIPAA applies to privacy protection for health services that are delivered electronically. So in essence, if you're doing long-distance counseling by video conferencing, you're transmitting the actual raw data during that entire session, which has the capability of being recorded and a number of things. And some guidance on the actual application of HIPAA to services that are delivered through telemedicine would be very valuable. Thank you.
Okay, time for answers. No. Do I get to ask questions? So in terms of the basic topic, the Omnibus final rule, are we done now? It started with well, it may depend on what seat you're sitting in, and certainly if you are a provider or a business associate or responsible for the implementation, heavens no, you are not done yet. Even though from the seat of the regulator and the enforcer, which is my seat in the world, we're not done yet either. And I suppose the question is not whether we are done yet, but are we where we need to be in terms of privacy and security of patient data? And until everyone agrees that we are at that place, then we will never be done. So stay tuned. There will always be another opinion, which, if it has enough support, will become another statute or perhaps another regulation. With that in mind, we are done, at least with this one piece of regulation. It was a big one for us, and an important one. And through what you heard today, particularly the change that affects business associates and how they do business and how they can now be held accountable for how they do business. I think that is a tremendously important step, and it really will be transformative, I think, in terms of how the impact of the HIPAA requirements much more deeply across the industry, in terms of that becoming a broader standard, not just one that affects providers and health plans. But while the regulation is done, and thank you for the compliments on the preamble, we worked very hard to try to get out as much learning that we had during the course of writing the regulation to help people that are now going to take this and make it a real thing in the real world. We understood that there's a lot more to be done. We have made some major steps in terms of getting guidance out, but much more needs to be done. We do currently have available on the website a major piece of guidance on how to go about de-identifying information. So if that's an area of interest for your business practices, or in this new world of HIPAA accountability, if you want to move away from using identifiable information and try to conduct your business solely on anonymous or de-identified information, I think this guidance will be very helpful to you in explaining in more detail than we have in the past about both how to do it through the safe harbor method, as well as how to do it using an expert, particularly though as we are moving into bigger sets of electronic data. The ability to de-identify that through expert determinations, I think holds much promise to protect privacy, as well as to make the data much more usable for the end user. Mobile devices, yes. We are very concerned and interested in mobile devices. We in cooperation with ONC, do have up on the Health IT website a whole suite of guidance and tips on how to secure mobile devices and what can be done to protect the information that's on the mobile devices. And so that there's videos and other things that are downloadable, fact sheets and other things that are downloadable. There's also, we have posted the Business Associate Agreement sample on the website, and we have, in cooperation with Medscape, put up a series of about 3 videos and information that can be taken for credit that go to how to build a culture of compliance within your organization, and how individual rights can be provided in a provider setting. For the consumer, we do have a variety of fact sheets on HIPAA, and we have them in 7 different languages that are available on the website. And we also have a YouTube channel, woohoo, where we have a variety of videos, both largely for the consumer, but there are some that are there, and we are getting close to 500,000 views of those YouTube videos, so we're quite happy with those. But much more guidance in the pipeline. We are looking to put out a breach risk assessment tool to help people apply the 4 factors that we introduced in the Omnibus. We are working on minimum necessary guidance, although that is much more of a work in progress. We have a number of HIPAA training, computer-based training tools that we created originally back in 2010 when we were required, or when we decided to go out and train the state attorneys general, since they have new HIPAA enforcement authority on their own. So we developed this training package, and we have now adapted it so that it speaks, instead of to state attorneys general, it speaks generally to covered entities and takes you through HIPAA front to back, and it also has been brought up to date for to incorporate the new high-tech provisions, and we are in the final editing process of getting those ready to be launched. So we are developing other fact sheets and FAQs to support all of the areas that we changed that were affected by the omnibus changes. And even once we are through that, there are certain regulations that are still in the pipeline. So, you're not done yet. We're not done yet. One of those was mentioned just this morning, and that is the opening up clinical lab test reports for direct access. And that is a joint rulemaking that we are doing with CMS, who is responsible for CLIA. So it's an amendment both to the CLIA side and to the privacy side that will open up the ability of individuals to get their test results directly from the labs in most cases. And that is, yes, there will be a final regulation. It is working its way tediously through the clearance process, but it does live. We are also working with the Office for Human Research Subjects Protection to move. There was an AMPRM that was published not too long ago to make some changes in the common rule. And that also is working its way. It has to go through the notice, proposed notice of comment, and that work is also progressing, and we are cooperating with the department in terms of providing better data security standards and more explicit confidentiality standards to be incorporated as part of the common rule, and to hope and to better align the tension that always exists between the HIPAA requirements and the common rule requirements when it comes to doing research. So that is working its way through the system as well. And then we did just publish, and the comment period ends tomorrow, another advance notice of proposed rulemaking. And this is asking for responses on whether there are HIPAA privacy barriers that states experience in trying to report individuals who are subject to a prohibition on owning or buying a gun to the I'm trying to remember what the database, we call it the NEXT system, the National Criminal Background Check System, which deals with licensed gun dealers to let them know if an individual who is there to purchase a gun is prohibited. One of the ways you can be prohibited is if you have a mental health condition where you have been involuntarily committed or otherwise present a danger to yourself or others, and therefore are prohibited from owning or purchasing a gun. And we had some issues. Certainly Newtown brought this to light, although it didn't directly implicate the reporting system, but nonetheless it is we are asking the question, is HIPAA a barrier to entities participating in reporting individuals into this system? So I hope I do have an opportunity to either answer your questions and to see if I can respond to the panelists' questions, if I haven't touched on them.
So let's throw it open to the audience. Professor Evans up there, now having had all her questions answered, won't be, I guess. What questions for the panel? I guess one sort of comment while you're thinking about that is I still think, or hope maybe, that a tension that's come up in quite a few questions from the audience over the last 2 days, and which is related, Sherri, to your minimum necessary point. We still live with a very broad TPO. And some of us have argued for many years that it's overbroad, and that, for example, in the treatment area, it should be narrowed down to the medical domain or the treatment team or something like that. And as Sherri points out, more guidance on minimum necessary, I think, is there. The other broad point I'd make is that we have very much been talking about today's topics from this conference. The medical information that is circulating within the traditional medical domain. We have not talked about, and luckily your department does not have to talk about, the stuff that we talked about yesterday, which is the data that's flowing outside of the HIPAA-protected zone, if you like. And I think that's a conversation that we're going to be having more and more over the next few years. When HIPAA came out, when President Clinton and Secretary Shalala walked into the Rose Garden that day and said, "Kids, you got a new toy to play with," we thought at least we knew the outside barriers, the size of the thing we're dealing with, and we didn't. The amount of medical data or medically inflected data that's circulating outside of the traditional domain in mobile devices, for example, that are not controlled by covered entities, but are controlled by patients. Right. And what sort of protective models are we looking at there? That's going to be continuing, I think, that massive conversation. But now we already have volunteers, so yes, sir.
He was here first.
Oh, okay. Sue, I was very glad to hear about everything that's happening on the website. I know that OCR has always been very proud of how much information they've made available to the public, including, I was especially interested in a couple things I haven't seen. As you may know, I had a hand in doing that, the SAG, State AG's education product, and I didn't know that was made generally available. And that plus the videos that you described are both very exciting to me, because it seems to me that one of the biggest problems we're still facing that is a huge challenge is sort of getting providers and HIPAA-covered entities not just to comply, but to value privacy. I'm going to share just a 3-sentence story. I had the worst physician interaction I've ever had about a month ago. I walked into a doctor's office and I was asked, "What do I do for a living?" And I said, "Well, I'm a privacy professional with the government." And the physician put down her pen and looked at me and said, "I want you to understand, I'm already not paid enough to do what I do. Privacy is a waste of my precious time, and all information is not private if it's electronic. So if you really want privacy, we have to go back to paper. So just keep that in mind while you're doing your little job." I won't be going back to her or that office. So I'm wondering if anyone on the panel has any thoughts, in addition to some of the things that you've put out there now on the website that I think are helpful. What can we do as patients, as the privacy community, as the government, or as in the private sector, to continue to get providers to embrace this, not just as something that needs to be done, but something that ultimately is critical to good patient care? I mean, I felt like I was sitting there hearing, "I do not care about your safety, your well-being, your health. Get out of my office and let me do my job." And I'm wondering if there's anything more that we haven't already done that we can still do to get this message out there from the point of view of any community.
I'll take a shot at that if you don't mind. I think we've got to tell the stories. We've got to tell your story. We've got to tell stories that connect, moving away from this regulatory, paper-based, restrictive view of HIPAA and high-tech and Omnibus, to telling stories of how it's actually impacting the patients. And I think that's a theme of this conference. I don't think we're too far off base there. But in terms of getting that message out, I know Candice and others in the covered entity side have training and awareness programs more geared toward the staff and nurses and employees and such. But the physicians have to be part of that community, and I think that's the forum you need to start telling some of those stories and making it more personal and helping understand that it's more than just a regulatory requirement. It's more than just a pain and a restriction to their job. That it really does have impact. It really does matter. And I won't tell the stories I think they've been being told throughout this conference, but that would be my perspective.
I'll just, to second that, in terms of telling the stories, I found in training, it's by far the most effective approach, especially with respect to breaches. You can talk about we can be fined or we can be audited and then we have to do this and we have to report that, but the human piece of it, the security piece, and my organization especially, all of our members on the healthcare side, it's managed long-term care, so they're either extremely ill or generally very old and extremely ill. So the getting across them the vulnerability there, not just with someone using their information, but even using it in a criminal way to come to their home. You know, they know where they live, they know how old they are, they know, you know, that they're receiving managed long-term care, and maybe they have dementia, and people abusing that. That's by far been the most effective approach, I think. But the other thing that my office tries to get across is bringing privacy out of the regulatory aspect, but back to the care. You know, it should be part of your care model. Valuing privacy and your patient's confidentiality and the privacy of their information. It's just an extension of providing competent care to that individual. And I think if you can relate that to physicians and providers and in a way that they understand, it's not just some checking boxes and making sure we're doing everything we have to do, you know, on a regulatory perspective, but that we're really giving the best care that we can down to protecting their privacy and respecting that and valuing that.
Yeah, one quick addendum, if I might add, it's in the Hippocratic Oath, right? If you have a physician that's giving you flack about privacy, it says, "I will keep your information safe and secured." It's there, you know, it's a core part of their mission, and I think that would probably be the first thing I'd want to say to that physician in that scenario.
I think, HIPAA from the very beginning has faced an educational challenge. I mean, it's extremely difficult to explain HIPAA to patients or to providers. And when something is very difficult to explain in simple language, in core concepts, then it is viewed as technical language. It's like the same way doctors don't really like informed consent. For them, it is not an autonomy device. It is a list of checks that they have to put in boxes, and it's awkward and time-consuming and gets in the way of medicine. And they feel the same way, therefore, about privacy. One of the reasons why people have been very welcoming during this conference of our friends from Europe and have desperately interrogated our constitutional law professors about what the Supreme Court may be doing, is that those organizations tend to speak in broad principles. And the privacy language that we have at the moment is very difficult to reduce to those principles. But I see it more and more coming from professionals like yourself and from Leon this morning, of being able to simplify things down and make points more directly, and maybe that's the beginning of a new trend.
Thank you.
Thank you.
I've got one kind of specific question, and we work with physician practices doing risk assessments and helping them get HIPAA compliant. And a lot of times they'll tell me we have a laptop, it doesn't store any information, it only accesses the information. So they're saying we don't need to encrypt that, we don't need to protect that, because all it's doing is accessing it, and we have a username and password. I feel that encryption is necessary on those drives. Do you feel the same?
I'll take that if you don't mind. There's two answers to that. One is, you know, the safest route you can go is to encrypt those devices, just to get the safe harbor, to leave the debate out of it, you know. But there's a cost associated, so I understand that. There is the concept of compensating controls. You know, if you have what we call compensating controls, meaning there are other security mechanisms or technical mechanisms in place that truly do prevent any information from being stored on that device. Now, it's usually much more broad in terms of the restrictions that would be on that than just oh, I'm going to access through, remote access technology like Citrix. That's not enough. It really needs to prevent you from storing information on that device, and there have to be that device needs to be locked down much further than typically it is to qualify for compensating control. But there are ways to do it without encrypting. But my general guidance would be to go the encryption route, if at all possible.
And I agree what you all were saying before. The thing I find when going into an office is if you talk to them about HIPAA as government regulations, it's just another thing that they don't want to do, that they don't want to go after. But as soon as you start talking to them about, this is patient privacy, this is helping protect that information, and then pointing out some of the things that they're doing that are just so wrong, wireless networks that are unrestricted, that anybody can access, those type of things. When you start talking to them about that, then they kind of get it and they kind of are much more favorable to it. But I just heard a statistic the other day, 80% of offices have not had a security risk assessment. And out of those, only 2/3 of the ones that have, or 2/3 of the ones that have had the risk assessments haven't had an adequate risk assessment. And is there going to be more guidance, especially for companies like mine, in helping and being able to show this is what the government really wants you to see? Because I go into some offices and they say, well, I got this online, it was 5 questions, I did my security risk assessment. And I'd like to see more guidance, to help companies like mine help get these practices compliant, because right now, they'll ask me, well, what certifies you? What makes you a HIPAA, security risk assessment expert? And I basically say it's just all the studying and training that I've done, going through everything. But there is no certification. There is no more real guidance on what it has. I've gone through the HRS, the toolkit. So, there are those things out there. But is there any other sources or any plans you have on providing more information so that the doctors can feel comfortable when they spend money with me and with other companies that they're actually getting something of value to help them move along?
Sue?
Well, I think right now our efforts really are directed more toward trying to make risk assessment really a more accessible concept for the small provider offices. We do have a risk assessment tool currently on our website, which explains from the security rule perspective what you need to do to conduct a good risk assessment. We also have on our website the protocols that were developed for our audit pilot, including the protocols for how those audits approached the compliance with the security rule, including the risk assessment. And we are working with ONC to try to provide even more tools that would translate the security rule requirements and in particular the risk assessment needs and approaches, so that small providers will actually hear what we're saying. And we wind up having one of these, we think we're speaking plain language, and we just get these blank stares coming back at us. And so trying to find what are, what words do you need to hear? How can we say this so you understand, A, what it is intended to accomplish, and B, that you can do it.
Right.
This is something you can do. This is something you should do. And this is really just reasonable common sense requirements for the ultimate goal of keeping patient information safe and secure. And I think we are, in cooperation with Medscape, looking to do an additional component that does address security and risk assessment. Again, trying to find a level at which we can discuss that in a way in which we can discuss that so that the providers, the practitioners that use that website to get some credits can again get the message and take that message home and actually do something with it.
Tremendous. Well, I don't think I've ever been on a panel where all of the panelists stayed to their time so well and also attempted to answer the question. So I thank them and I thank you for coming.